shared via the Scirocco Exchange website. So it should be up on the Scirocco Exchange website within a few days. Certainly by the end of next week, we'll have it available if you want to share it with your colleagues or if you want to listen in again. And Andrea, we can see your slides, and I'll hand over to you if you would like to start.
Thank you very much, Nessa, for this introduction. So my name is Andrea Pavlikova, and I have a pleasure to coordinate this Scirocco Exchange project. So as Nessa said, the objective of my presentation is to give you a brief introduction to the maturity assessment process, to really set the scene for the practical examples that you will hear from 3 different regions and countries in Europe. So this maturity assessment process is conducted as part of the EU-funded project Scirocco Exchange, which aims to provide practical support for health and social care authorities to improve their capacity for integrated care. And for us, the main facilitator of this process is what we call this Scirocco Exchange Knowledge Management Hub. It's the hub that we are working on in terms of its development. And we see it really as an online sort of like matchmaking platform between the needs of these health and social care authorities and solutions that can help them to address their local priorities, local priorities. Within this process, we realized that in order to provide this support really practically and effectively, one need to understand very well this local context and local conditions enabling integrated care. And that's why the first functionality within this hub is around the maturity assessment for integrated care, which help us to better understand these local priorities and areas for future improvement. And what I would like to also emphasize when it comes to the functionality of the hub, we really see it as a tool which helps to use the existing evidence, the existing experience in integrated care rather than trying to reinvent the wheel. So when it comes to the maturity assessment, which is, as I said, the first stage of this knowledge management hub, the main tool or the main facilitator of this process is this Scirocco tool for integrated care. It is an online self-assessment tool with the objective to capture people's perceptions on the progress towards integrated care. So it's not the evaluation tool or the objective measurements, but really the tool that is trying to work with stakeholders and try to understand how they perceive the current situations, and more importantly, where they would like to see the actions and priorities moving forward. The tool is free to use for everyone who is interested. You can just use the link which is provided above and create your account and use it for your local objectives. As you can see from the diagram, the tool consists of 12 dimensions. Each of these dimensions represents a particular effort that needs to be provided to deliver integrated care. And you can see a mixture of domains, domains which are much more strategic, like governance, readiness to change, but also very operational domains such as infrastructure, capacity building, and so on. The tool has been so far used and tested in over 72 regions and organizations, and we are really very much looking forward to any inputs and any feedback of the users so that we can constantly improve and enhance this tool. It is also available in 9 languages, and I would like to emphasize that when it comes to the translation of the tool, it's not really only automatic translation, but really the adaptation of this tool to the local circumstances, to the local culture, to the local understanding of integrated care. When you enter the tool, attention is further defined in terms of the objectives we want to achieve against each of the dimension, but also more importantly, the assessment scale. So it ranges from 0 to 5, and we can see there basically the different level of maturity you can achieve against this dimension. And once you do the scoring against all 12 dimensions, you will end up with this visualization with this spider diagram, which you see in the right corner, which basically provides sort of like a very quick detection of the areas where you are quite strong, you are achieving quite high maturity, like as you can see in the purple square on the right, digital infrastructure. But also on the other hand, you see the areas where you are scoring quite low, like for instance, removal of inhibitors, finance and funding. And you can use these insights in 2 different ways. First of all, I think it's important to highlight that you can capture individual perceptions of stakeholders in your system or in your organizations or within your teams. And so it's very actually interesting to capture these individual perceptions, get insights into how particular disciplines or particular stakeholders think. So you can also use these individual perceptions to compare the teams or compare particular disciplines, and the tool fully support this function from the technical perspective, which you can see on the spider diagram, which is a composite diagram of few different responses of stakeholders. So you again very quickly can see how different stakeholders are thinking, where there are areas where they tend to agree or areas where they tend to disagree. And we are then working with these individual perceptions to actually bring these stakeholders together and have some structured dialogues and structured discussions on how they perceive the situation in their system or organizations, but also work with them to actually agree on the final level of maturity. So it is really also the Scirocco tool is also very much perceived as a facilitative tool, which makes people to reach the consensus, to reach and sort of like on their maturity. But importantly, as part of this exercise, as part of this facilitation, they also have to agree on the future priorities or future actions to address particular gaps identified during this process. So if you look at the maturity assessment process itself, again, I would like to highlight that we are looking at capturing people's perceptions, how they see the maturity of their systems or organizations in integrated care. And we are using it to build some discussions, build some dialogues about way forward. So it's capturing the current state of art, but it's also sort of like a planning tool which can be used within these stakeholder settings to agree the actions moving forward. What I would like to highlight as well is that this process is very flexible. We are not prescriptive in terms of which organization or which level of the healthcare system this assessment can be done at. It is really tailored to your local circumstances, to your local needs. So you will also see from today's examples that actually this process has been applied at a very different levels for a very different a group of stakeholders and in different settings. So it really does allow you to tailor this process to your local circumstances and your local needs. In general, regardless of what kind of scope you choose, we basically conduct this process as a 4-step process. So we start with obviously identifying the stakeholders who are participating in this assessment process. Again, we are not prescriptive here who needs to participate in this process. It fully does, it fully depends on your local situation, your local structures of the healthcare systems or organizations or the teams. But we strongly advise that these teams are multi-stakeholder, so that we have people from different sectors, different disciplines, and also different seniority in their organizations to really reflect the diversity of stakeholders working on integrated care. And we also work with very different size of the stakeholder groups. So, we have, in some cases, we have like 10 stakeholders participating, but also we have really large groups of 100 and more stakeholders. In the second step, these stakeholders are all asked to individually and independently conduct their assessments. So it's that everyone needs to contribute and everyone needs to independently provide what they think about the current systems. These outcomes of the individual assessments are then shared, and there are also various options how you can share this data depending if you want to share your assessment with the whole Scirocco Exchange community or the users of the hub, or you can just, you may prefer to keep this assessment just within your teams or just within your organizations. Again, it's very flexible. And in the final stage, we are basically then using these individual insights, as I said, to facilitate these dialogues, have a constructive discussions, and basically leave the room with the final understanding of the scoring and priorities for future. And I will actually stop here because I think you will now basically hear from 3 regions how this process can be practically applied. And as I said, it's in this experience that you will hear from, it's really at a different levels, at a different scope. So it will give you the opportunity to see the flexibility of this process. Thank you very much.
Thank you, Andrea. That's perfect. I appreciate there's a lot of information contained within the slides. I'll just ask Saul to start to share your screen, please, if you can, Saul, while I introduce you. And as Andrea said, now we hand over to 3 different perspectives from the regions who are using it. And the first up from Belgium, from the Flanders Agency for Care and Health, we have Solveig Bollen. Apologies, Saul, if I've pronounced that poorly. And I know Saul's colleague, Karel, he's also joined us. So if there are any questions later on, that I'm sure he can join in the answering. So Saul, if you can share your screen with us, that would be brilliant. Yep, there we go. That's perfect. So just to remind everybody, we will pause after speakers for questions and to use the chat function if possible, also to capture any questions as we go along. And Saul, if you can put your screen into slideshow, that would be great.
Yes, I'm trying to. Sorry. Oh la la. I just can't get hold of the bigger screen for the moment.
You can see it as it is. It's not critical, but if it's not
right.
cooperating.
No, it's okay, but I can't see it myself. It's a bit weird.
Okay.
Can you still see it?
We can see your screen. Yeah, we can see it perfectly. We can see your slides.
Okay.
It's not in slideshow, but we can see it fine. And
Okay.
I think we can read it. Andrea, can you see it clearly? I won't ask everyone.
I can see it. Yeah.
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 But all right. I just can't get to the bigger screen. That's the point actually. Maybe now. Is it working?
Something's happening. No, it's not. I thought it was changing there, but it's not. It's not changing. So I think, Saul, as we can read it as it is clear enough to read for me, and I hope for others. We can read it. Yeah, Mia and Sophie have chipped in to say they can read it. So I think go with what we have, Saul, if that's okay.
Okay, that's fine.
As long as you can change through the slides. If you want me to do the sharing, if you want me to try that.
Well, can you do this? Because I can't get to the bigger picture. I have to say, I'm stuck with my my own screen and my own presentation, which is the one that I shared, but I can't see the sharing.
Okay, let me try it then and see. Can everyone see that?
Yes, perfect. Thank you.
Okay. All right, Saul, that's on my screen. So if you just let me know, if you just say next slide.
Yeah, okay, that's good.
I will be your beautiful assistant.
So, well, I think everybody knows now already that I'm Sol, and I'm working in the Flanders Agency for Care and Health. Yes, please, Nessa. And well, a little bit about our healthcare system in Belgium, because Flanders is one of the regions in Belgium, and how we started this journey on integrating care in Flanders. Now, I think Belgium is a rather complicated healthcare system. Probably everybody, but we do have a lot of competences that we share amongst the regions, and with not amongst the region, but between the regions and the federal level. And but with the second state reform, finally the regions became competent for the primary care. They were already primary health care. They were already competent for the primary social care. And that's where we started. Now, on your left side, you will see some 6 bullet points. Well, just showing you the characteristics of our healthcare system. There are 2 that I want to highlight for you. And that's the first one is the number 2, that in Belgium, we have freedom of choice for patients, which when you have to organize your care, of course, you have to take into account that people can go from left to right, and maybe 100 kilometers further, they will have their physiotherapist, and next door, their GPs. There's also the third bullet point is very important for us, and that is the independency for physicians, which means that we don't have an NHS system as such. So all this, well, put everything into working, and the way forward for Flanders was to reach out to the local level and to set up the system to reform the system by bottom-up approach and with a focus on multidisciplinary cooperation. Okay, Nessa. Next slide. Yeah, thank you. The objective for us in Flanders for integrated care is to reach towards person-centered and eventually goal-oriented care. I'm listing here a couple of documents that I thought might be of interest for those who want to know more. The first one, the strategic vision on the reform of the primary care is translated in English, so it gives the tale of the complete concept. The second one, the Flemish, in parallel with the reform of the primary care, Flanders developed a social protection, which is an extra layer to the normal social protection or reimbursement of medical care. Here it is about non-medical care reimbursement. And of course, there's a lot of legislation. And last year, the legislation was there to install the Flanders Primary Care Institute, which is called for us VIVEL, and 60 primary care boards. I will come back to both of them later on. But when you speak about integrated care, and for us it's about health and social care to integrate, you know as well that we need to think about the hospitals, what their role is in the future, and that's very important as well, and it was captured in a green book for the hospitals of the future. Okay, Nessa. Next slide, thank you. What does it mean for us? I think here what I'm trying to explain to you is that it's a complete reorganization. I'm not sure how it is in other countries or regions, but we had in Flanders a multitude of different structures in healthcare, in social care. Some of them working together, some of were not working together, and so it was clear that we needed to do something to bring them together, not specifically to dissolve them or to get rid of them, but really to merge them and to make them work together. And you see there 3 circles where I think the most important for Flanders is the smallest one, the primary care zones, closest to the professional who is taking care of a person with a need. There are 60, I already mentioned it, there are 60 care zones. They have been identified. They are governed also, each one of them, by a board. And you can say who is sitting in on the board are patient organization, GPs, physicians, the informal carers, nurses, the local authorities. And that's for us, I think, really the focus, the main focus will be put on organizing and giving them ample opportunities to get the integrated care organized at the local level. Around this, the second layer is what we call the regional care zones. I think there's some 15 regional care zones. So they also embrace the primary care zones, but they are more linking up with the centers of expertise, such as in prevention or in palliation, dementia, mental health. And the new layer is the Flemish Institute for Primary Care, VIVEL, who is our center of excellence. And normally I should have been here together with one of my colleagues, Karel, but he is joining this webinar as well. And I'm expecting that he may also intervene later on when you have questions, because he is more a specialist than I am in this area. Okay, Nessa. So yes, Vivel and my colleague Karel and his other colleagues, they have been very active in the whole maturity assessment process because from the start when we joined a Scirocco project, the intention for us was really to bring and to bring the assessment tool towards the primary care boards. So the first step for us was not, since I forgot to mention that the primary care boards, they do exist, but they are getting themselves organized and probably will become fully operational next year, so in 2021. So the first step is that we said, fine, let's use the self-assessment by the governing board of Vivel. This board is composed by 15 members and 12 of them participated in the self-assessment. Who they were, well, there's mostly the umbrella organizations, but they give a good representation of the Flanders local situation in the primary care boards, like on patient organization, insurance company, and other organizations. The only ones that did not participated and were the cities and communities organizations. Okay, next one. And that's for them that we're doing it. Here you see our Flanders visualized geographically with 60 primary care boards. Okay, Nessa, next. And well, yes, there was a very interesting process. So all the 12 stakeholders managed to participate, to give their own individual consensus. I have to admit that my copy paste is not really very successful, but I think if you look at the spider webs, that it's quite clear that we had that we have a lot of room for discussion. Okay, next one. And this discussion that came on the 16th of January in our consensus workshop. Everybody participated and we adopted a very interactive approach. Like you can see, the people here to the left are representing for this dimension. I don't know which dimension was discussed there, but they are representing the ones with the lowest score, and to the right with the highest score. So it was the intention that everybody was explaining why the score and then coming back to each other and discussing and sharing the different opinions. Very, very interesting moment, I have to say, really, because people try to understand why there is a difference in perception and in the situation, which makes it very nice. Yes, thank you. And that is how our spidergram is looking now. I like very much the idea of Karel. They say that it looks like a fairy from one of the Walt Disney movies, and I think he's right. But as you can see, we didn't discuss all 12 dimensions. We sticked to the to 8 dimensions where the scores were most divergent. And when you look, for example, at the two ones, the ones, there's two, we started with the two with a 0 and a 4 or 5, and there was a structure and good governance, which is the second one, and the 10th one is breadth of ambition. It's you can see also that we managed in the consensus to reach a higher score for structure and good governance. At the other hand, the breadth of ambition was a different discussion and different consensus. And when I remember the discussion, I think that it's also because if you work in a more structured environment, like more at the regional level, you feel that the ambition is high. But once you start talking to people at the local level, they feel insecure. They don't know if they will be, well, really, if they have all the necessary tools, if they will manage to integrate it, to implement the approach of integrated care. Now, I think also in terms of what can we consider in Flanders as success factors or as challenges, I have to say this is my perception, because for the follow-up now in Scirocco, we will have a look also in Flanders on the topics that we would like to see, more better approach that we would like to put in focus on. But let's say for the success, I think we managed pretty well in the reform, and there was a lot of preparedness for change. That's the first one. At the other hand, for the what I would consider as really as necessary to put on a focus is on the empowerment. Health literacy, it's also from my own perspective, is a lot of initiatives, but we need to do better in Flanders. And then definitely the population health management. Okay, Nessa. I think here I come to my last slide. I think I have more than half a paper of take-home messages, and it was, I just took them over from the discussions from the stakeholders, and I think the biggest one, the most important for us was, since we were testing the tool to see if we can really apply it to the local level, is that we see that as well with the partners in the Scirocco project and also the tool, we have the necessary flexibility to amend the different dimensions to the local situation. I think that for us was really a very important point, because and probably that this will be in other regions as well, that your local level is looking differently towards, for example, population health management. Risk stratification is a concept that maybe not everybody understands, and at the other hand, also financing mechanisms is not always that easy. So but it's fine. We can work with it, and basically, I think this is it for me. Thank you very much, Nessa, for taking care of me.
Thank you, Saul. That was perfect. Thank you very much. I'm going to ask our next presenter, who will be Sophie, to get your screen share ready, if that's possible, just while we change over. I think it's very interesting also, a point for Saul, and just more generally with the speakers, and I'm sure Andrea would say we have seen this in other regions which have used the tool, that it opens up the possibility for a conversation. I think you drew that out very nicely in your presentation. So the different perceptions between the staff, depending on which part of the organization they work in, or which level of the organization maybe they're in. That's very interesting. Okay, so Sophie, we have your slides in front of us. I'll just introduce you properly. The next presenter is Sophie Wang, and Sophie is presenting in Germany from Optimedis. Sophie, we can see your slides. If you can put it into slideshow view, that would be perfect. If you can't, we can still see it and read it. And if you can also unmute yourself, if I can do that for you, unmute. Okay, Sophie, can you hear us okay?
Yes, thank you. I was trying to figure out how to unmute myself.
I can hear you.
Okay, perfect. Thank you. So hi everyone, my name is Sophie, and I'm here to present on our experience here in Germany in using this Scirocco Exchange Maturity Model tool. I'm leading the Scirocco Exchange from Optimedis, and I'm joined here today by Fritz, my colleague, who is part of the management team at Gesunde Wehrmeisterkreis, which is our integrated care system. So today I'll be briefly giving an overview of Germany's healthcare system and a background on our integrated care system, just to set the stage for the project, but I'll mainly be focusing on our process of maturity assessment. So Germany has a healthcare system that's based on the Bismarck model with 4 underlying principles. Firstly, compulsory insurance with over 90% of the population that are insured. And secondly, funding through insurance premiums, that is a percentage of each individual's salary with equal contributions from both the employers and employees. And thirdly, this idea of solidarity, where everyone is guaranteed access to healthcare. And lastly, self-governance. Now, this idea of self-governance has eroded in recent years and is seen as one of the root causes of a lack of coordination in care and continuation. So one of the ways that it manifests is that Germany's healthcare system is divided into 3 separate sectors, so outpatient, inpatient, and rehabilitation. Each of these sectors have its own funding streams and compensation schemes. And this lack of coordination between the sectors can really be seen by the lack of information flow between each of the sectors, as well as a lack of incentives for professionals to really be working together to provide coordinated care for patients. So all of this, as I have already mentioned, can really be seen as one of Germany's largest healthcare challenges of today in terms of a fragmented yet highly regulated healthcare delivery. So in terms of our integrated care system, it's set in Werra-Meißner-Kreis, which is a town in the middle of Germany. It's set in a countryside with a population size of around 100,000. And historically, this region was situated in a more economically deprived area, having resided right on the border between East and West Germany. And that in itself we can see today in terms of the aging population structure and outward movement of young professionals to seek better economic opportunities. So in terms of the priorities that this region is seeking in its healthcare, includes first a development of a robust digital infrastructure to really meet the needs of healthcare access to a more senior population in the countryside, to attract and retain young physicians and nurses to revitalize the healthcare workforce, and thirdly, to really break down silos and foster this interprofessional collaboration. So, starting last year, Optometis has worked with various stakeholders to launch our newest integrated care system in this region. And as with most integrated care systems, we really aim for and evaluate ourselves against the quadruple aim. So namely, improved provider satisfaction, improved patient experience, reduce the per capita cost of care, and above all else, to improve the population's health. So we employ a horizontal integration to better integrate medical care together with social care, and which includes partnering with different social and nonprofit organizations, municipalities, as well as different healthcare companies within the region. And some of the areas that we focus on includes a focus on prevention and health promotion, including rolling out at various stages different types of programs and materials to help our residents better self-manage different types of illnesses. We heavily invest in health navigators, who are professionals trained in healthcare that have the capacity to support patients in navigating today's complex healthcare system. And thirdly, we really invest in interprofessional collaboration, where we hold regular quality circles and invite professionals from different backgrounds to come together and discuss different quality improvement topics as they arise. And lastly, we have a large emphasis on really building up a strong digital infrastructure. So through our involvement in the Scirocco project, we've really had the pleasure to test drive the Scirocco maturity assessment tool here, and have found it to be overall quite a constructive process in terms of helping us better understand where our successes are so far in our early stages of development, and also where we need to improve and pivot. So we first rolled out this maturity assessment tool back in October and was met with our first challenge in terms of the language barriers. And so we invested in translating the Scirocco, the maturity assessment tool. And following that in November, we had sent out an online version of the maturity assessment. And unfortunately, we were still met with quite a low response rate due to some difficulties in terms of accessing this online tool. So following that, we decided to invite all interested stakeholders to an in-person focus group to further discuss this maturity assessment tool in person. So this is a photo of the focus group that was held. We were joined by various stakeholders for a very lively and participatory session. And from the stakeholder groups, we can see that there were network physicians from our network and different healthcare professionals, as well as representatives from different professional associations that had came to participate in this process. So, on the day of, as I had mentioned, it was we had an in-person facilitated focus group that lasted for 3.5 hours, and the process that we employed was that each of the participants were asked to assess the level of maturity that they felt the integrated care system was at within each of the domains separately. And following that, everyone came together to have a facilitated discussion around each of the domains. And questions that had, or domains that had like the highest variance, really provided us with an opportunity to further discuss and deliberate on different perspectives. So this is just a refresher of what the maturity model looks like, and I specifically want to do a deeper dive into the citizen empowerment domain. So in terms of how this domain is defined within this maturity assessment tool is that an integrated care system is at a high level of maturity when services and tools that enables convenience, offers choice, and encourages self-service and engagement in health management is provided. So it's really about engaging and empowering citizens to better manage their own health. And when we had asked all our stakeholders to rate the integrated care system on this dimension, we had a variety of different responses from 0 to 4, as you can see. And when further probed, we found that from the perspective of certain stakeholders, a large amount of information was made available to patients. However, physicians did note that although this information was available, it's not very accessible to patients, as most of the times physicians are faced with patients coming into clinical visits to ask for various types of health information to be printed out. And so after thorough many rounds of discussions, the group came to a consensus and gave a rating of 2 that best reflects the situation from a patient's perspective. So this is the overall results of our integrated care assessment. And as you can see, we've rated ourselves mainly in the 1s and 2s, which we feel is quite an accurate reflection of our integrated care system so far, as we're still in our early stages of development. And now I'd like to share some of the successes and challenges that we've experienced when using this tool. So first of all, in terms of our successes, we really found that having a dedicated leadership that truly recognizes the value of integrated care and having the necessary experience in leading and implementing this to have a great impact on the successes that we've seen so far. And secondly, we've had some early adopters amongst our healthcare professionals, as well as other involved stakeholders, that really embrace this openness to change and particularly different ways of working together and collaborating. That really facilitated the growth of our integrated care system. But our experience, of course, is not without its challenges. We've seen a lot of different structural barriers in terms of having the necessary infrastructure to implement and sustain a robust digital platform that could be better utilized to coordinate care. And we're still in the process of overcoming that, as well as having different resources to really engage a wider population in this initiative. So overall, I would say that using this tool has really provided an opportunity for us to self-evaluate and have a really constructive discussion around the status of our health integrated care system and to provide further direction. So that's it for me. Thank you.
Thank you very much, Sophie. Excellent, really interesting insights yet again. I really like the point about leadership and wider engagement, especially. Sometimes I think we feel in health and care that we're explaining things very well and very clearly to groups of staff, but that is not necessarily how they receive it, is maybe the easy way to put that. We're going to hand over to our next speaker, and then we will pause for questions and have time for a bit of discussion. So if I could please ask Mia from Puglia in Italy to share her slides. with you, and hopefully we can all see them. I'll just give you a moment to change over.
Stop, Sophie.
Oh, sorry.
I will do it. It's okay.
That's all right.
Okay, so you
There we go. Perfect.
should be seeing my
Yep.
screen now.
That's it. We have it. Perfect. Thank you.
Okay.
So I should introduce you properly from the Regional Strategic Agency for Health and Social Affairs in Puglia, Efthymia Panzartis. I know I'm saying that really
okay.
bad. If
It's
nothing
okay.
else, I'll give you a smile. But Mia to me. Thank you.
Okay, thank you very much, Nessa. Okay, good afternoon, everyone. As I've already been introduced, so I am Efthymia Panzartis. I'm the assessment manager for the Scirocco Exchange project in Puglia. I'm here today on behalf of the Regional Strategic Agency for Health and Social Affairs, ARES Puglia. So I will briefly introduce you to the healthcare, give you a bit of context, introduce you to our healthcare system here and what we're currently doing on integrated care in Puglia, and then take you on the maturity assessment process we have conducted here in Puglia, giving you a summary of the maturity results, taking to the conclusions and a take-home message. So Puglia is a region in the southeast, on the southeast coast of Italy, as some of you may already know. These are a few data. We have nearly 20,000 square kilometers area with a population of just above 4 million people. The life expectancy is 82.5 years old with 40% of chronic patients. I have to say that we have 21% of our population who is aged over 65 years, and the healthcare expenditure per capita is nearly 1,800 euros, and these are all data referring to the year 2018. So our healthcare system here is predominantly public. We still have private facilities that allow citizens to access the system undergoing the same rule of the public system. We have been undergoing a complete reorganization of services in the past years with a closure resulting in the closure of 21 hospitals and 2,200 hospital beds reduction and the reconversion of 5 hospitals in community centers. We are currently underway, the construction of 5 new hospitals as well. The services here in the region are provided through 49 districts, which are gathered in 6 different local health authorities, and these include integrated health community centers, primary hospital, secondary hospital, tertiary, and also research hospitals and 2 hospital trusts. So given this very quick context, what we want to achieve here in Puglia with healthcare is mainly to promote options to hospitalizations throughout care delivery closer to the patients. This in order to reduce the burden of unnecessary hospitalization for patients, caregivers, and also the local system. It is very important for us to empower the patient, herself, himself, and improve their quality of life. Doing this, improving the processes, improving the outcomes, and improving the quality of care, so their satisfaction. This slide shows you a representation of the integrated care model we currently have called chronic care model, which is at its 3rd version. You can see 3.0. The key element of this model is that we aim with this at improving horizontal and vertical integration within the system. So among the professionals of different services and throughout different care settings. So from the hospital throughout the territory, you can see the patient is inside, is at the center of this diagram, and also you can see the different professionals all around him. So this model was first rolled out in 2004 as a trial in only 1 local health authority. here in Puglia region. Then it was implemented at a second step, mainly addressing some specific disease categories. And then now it's being scaled up throughout the different local health authorities. This comprises the patient profiling and stratification by age group, disease, and risk factor. It is based on primary care clinic and health community districts. It seeks a strong engagement of individual patients throughout the individual care agreement. It involves GPs on integrated care units, and together with the patient, who is at the center of the system, it identifies the nursing care manager as a pivotal element in the delivery of the services. The patient is essentially in contact with his or her own GP through telediagnostics. Here in Puglia, we have, for the Scirocco project, we have undergone our maturity assessment process at local level. So throughout the 6 local health authorities, following the 5 steps everyone has in their methodology, so identification of stakeholders, they've completed their individual assessments, we have collected the data and done the analysis, organized the workshops, and then analyzed these data within the final report. So as you can see on your right hand of the screen, we have the 6 local health authorities. The engaged has been based obviously on information, consultation, participation, and feedback throughout each of them. Our stakeholders were asked each local health authority to identify a team of minimum 5 stakeholders with specific backgrounds, so specific and diverse backgrounds, top management, representative of the health and social care district, representative with medical background, which is, as I said, nursing care manager mostly, the representative of the IC team, and 1 or more representative of the patient groups. So this process has lasted 2 weeks overall. For the individual assessment online completion through the tool, we had 32 stakeholders who took part to the process from the start to the end. We have supported them with documents and and a dedicated helpline that was set up on purpose to support that during the survey. In the next slides, you'll see 6 pictures of the 6 workshops at the end of the process in the different local health authorities. This is one of the spider diagrams, the final spider diagrams originated for 1 local health authority. You can see it's Bari here, and the emerged strengths in this case were citizen empowerment, breadth of ambition, process coordination. The weaknesses for these local health authorities were finance and funding, digital infrastructure, and removal of inhibitors. Now, in this case, as for all the others, the other 6 local health authorities, these were influenced by very specific elements, very specific factors at local levels. So, and all the details are contained in our final report. This is a summary of the 6 different spider diagrams of the 6 local health authorities. The first one is the one that you have seen in big. And you can see from this slide that basically there is a lot of variation throughout the final consensus that was achieved in the 6 different organizations, different per scale, per type, per geographic distribution. This is a summary. This is a matrix that summarizes basically the 6 spider diagrams, the image in the previous slide. And you can see from here very clearly that at least there are a couple of dimensions which were recorded as major issues, major elements on which to improve. And these are finance and funding and removal of inhibitors, where we have 3 out of the 6 local health authorities providing a very low rating. So overall, we can say that there are Overall, across the 6 local health authorities, we have 3 main key success factors that are instrumental in this case, and these are strong ambition by multiple stakeholders, patients' involvement, size, and background of the organization. Also, we recorded 4 key challenges that are were equally recorded across the entire 6 local health authorities, and these are the morphological configuration of the territory, cultural and infrastructure gaps, organizational aspects, and communication. And I'll take you to the conclusions. The level of maturity of each local health authority health and social care system here in Puglia varies from medium to high, as you have seen in the matrix, in line with the 4-star reference site in EU Innovation Partnership on Active and Healthy Aging. One important element is that regional managers and clinicians, so 2 types of stakeholders, tend to score higher on the maturity progress in relation to each individual context more than the citizens' representatives do, as information is not shared consistently. The major strengths across the 6 local health authorities are population approach, process coordination, citizen empowerment, and digital infrastructure, while removal from inhibitors, finance and funding, and evaluation methods have still room for improvement. The emerging picture overall reveals a very dynamic scenario in which several e-health good practices are on the verge of being scaled up, and the integrated care model is only one. As a result of a positive assessment by the regional HTA center, a lot of resources have been invested in integrated care delivery in Puglia. Nevertheless, cultural and infrastructure gaps may sometimes result in barriers. Inhibitors are still present, and this was one of the dimensions which was rated less among Puglia local health authorities, and require systematic and organized action to be successfully removed, such as knowledge sharing and training, and also the funding element. So funding approaches need to support the delivery of integrated care in a smoother way, so that the timeline, which was recorded as being one element of debate, is reduced and investments can be more dynamically made within a structured delivery plan. So our take-home messages are: the implementation of integrated care models is the only viable way to offer improved quality of life to aging population and efficiently respond to chronic care patients' needs in Puglia. Mutual learning and knowledge transfer are key if we want to achieve a sustainable and resilient care model for the future, given the constraints that we, but also many EU countries, are currently facing. The Scirocco Exchange tool and Scirocco Exchange program can work as an enabler for the implementation process of the existing integrated care model, Chronic Care 3.0, and multiple good practices disseminated across our region. And finally, we have some take-home messages specifically on the tool, which has enabled multiple stakeholders to provide ratings and justifications on 12 specific dimensions relevant to integrated care, very subjective ones as well. Stakeholders with diverse backgrounds and job roles to share and discuss their perceptions on these given dimensions, and the tool that has also enabled the local health authorities to fulfill information gaps and needs where appropriate, as appropriate. Thank you.
Thank you very much, Mia. That was perfect. Really, really good. Thank you. We don't have a huge amount of time, but I will very gladly take questions or comments in the chat function. I think you've all been frightened off by me from using the chat function, but I would encourage you to use that, or you can unmute yourself if you wish to ask a question to any of our presenters today. So I will let people have a moment if they wish to unmute. No questions? No, I don't think we have questions. I'm surprised. I would just like to make a couple of reflections before we finish, and I will hand over to Andrea if you have any comments or points you want to make, Andrea, or any of the other presenters. I think it's very interesting to see how the different perspectives of staff groups and citizens are reflected when you use the tool, and the gaps perhaps in knowledge and understanding. And I think, Mia, in your presentation, you clearly identified some issue there around information sharing and communication, but also the fact that citizen empowerment in your presentation was seen as a strength, which must be a bonus for the staff who are engaged in that work to see that reflected back in the process of using this tool. So I think that's a positive that we can take from it. It's not just about identifying where the differences are, but about areas where you feel you're doing well and that the work is going well. So we have some comments just in the chat function now, just saying that, asking if the slides will be circulated with the recording. And Andrea has answered that yes, they will. The recording will be available on the website, as I say, next week. And some thank yous. And I have a question also to all participants. Did participants change significantly their perceptions through the consensus process? So I think I'll start, Mia, with you as the last presenter. When you had your consensus workshop, could you actually see people significantly changing their perceptions in that process?
Okay, first of all, the first element I must share is that having had 6 different local health authorities, we basically had 6 consensus workshops. So we did notice this changing of perception, but not in all of them. I can certainly refer of one, and this was because the time was, there was a long time between when the self-assessment was completed. There were 2.5 months, and then the consensus workshop was run. In the meanwhile, they did implement the IT network. So there were lots of processes that were put in place as well. So in this case, for example, we noted recorded a very consistent, a very significant change in perceptions. In the other cases, sometimes with some stakeholders specifically, because they didn't have some knowledge when at first they completed their online survey. So this knowledge sharing was not done evenly or homogeneously throughout all the stakeholders, the different stakeholders. Yeah.
Okay, thank you. And Sophie, could you give a bit of response on that?
Hi. I was just going to say that I'll let my Fritz, my colleague Fritz, take this one.
Sure. Thank you, Fritz.
Fritz, I think you're on mute.
Sorry, okay, now I'm speaking. Okay, so I was mentioning this, for example, dimension 8 that Sophie showed. There was a discrepancy from 1 to 4. And anecdotally, the one pharmacist was insisting on number 4 and a physician on number 1. The view practically is that we have a running joke in Germany that a paper circulated in pharmacies called Apothekenumschau is the most widely read health information. So there was definitely a perspective, different perspectives, because one was surrounded by health information to incentivize people to change. The other one was a physician maybe seeing how people do not take up on that information that they provide in their practice. And that was a very lively discussion. In general, I think people saw, and agree with the previous speaker, they saw different dimensions from some questions, or like got a new perspective regarding some dimensions this way around, because they got information from other participants that they previously did not have, and then updated their rating. but I cannot speak for them internally, their internal convictions, but they definitely moved their rating.
Yeah, and we've seen that here in Scotland. I think Andrea would probably echo that in the consensus workshop, that simply bringing the staff together, and as Saul mentioned, having the opportunity for discussion, sometimes with people you didn't really know, and you didn't see their side of the work. So you had an opportunity to talk about what you felt and what they felt, and come to that point of agreement, or hopefully come to a point of agreement. Is that fair, Andrea?
Yeah, absolutely. I think that was our main conclusion, to improve the communication across, like internal communication and across the teams. So yeah, definitely.
Saul, did you want to come in, or Carol, your colleague? I don't know if you wanted to come in and say anything about whether you saw a change in the consensus process of perspectives.
I can leave it up to Karel. I think there's not a dramatic change, I think, but definitely it's worthwhile. People learn to know one another and to understand what was the opinion of someone else, and that makes it's not. I wouldn't say a change, but definitely people come closer together. Karel, do you want maybe to?
No,
to
I
intervene?
totally agree with what you say. So I also agree with Fritz, who says it's about the information that you have on that time, and also about the perspective on how you look to the questions. If you look from a Flemish perspective or from a local perspective, that it can differ to each other. And then when you come together, you get the information of the other one, and then it's easier to come to a consensus. So, okay, that's what I want to add.
I know it sounds obvious, but on reflection, but we don't often have the opportunities, I would say. At least my experience has been for staff to do that. So yeah, it's definitely worth it. Just a comment from Sandra, saying thank you all for the contributions and the different experiences. And what are the plans now for follow-up activities? I don't know, Andrea, if you're best placed to answer that, perhaps. I'm not sure.
Yeah, I can take that question. So from the project perspective, we are basically going to build on these outcomes of the maturity assessment. So each of the authority who conducted the assessment is now going to basically choose the dimensions with the lowest scoring to basically further work on the improvement. So we will be addressing these improvements through the dedicated knowledge transfer activities and improvement planning. So we envisage different level of support, depending on obviously different situations in the regions and organizations. So we will be conducting, study visits, webinars, exchange of staff, and various other capacity building activities to help to improve the situation in this particular area. And the last, so this is basically where we are heading now, and we are preparing for that stage. And this will basically then, the final step will be co-designed improvement planning with each of these authorities.
Thank you, Andrea. And I'm just going to now say thank you once again to all our presenters for joining us. It's been really excellent. I know it's a challenging time for everybody, and we're all working from home with other commitments as well. So we really appreciate your input, and also most appreciative for the 37, I think we had join us, 37 participants from the start of the webinar. That's been fantastic. I would like to say thank you, and the webinar will be on the website next week. And other resources are there if you want to check out the tool and have a little look and learn more about it. And good afternoon to everybody for now. Thank you.
Thank you.
Thank you. Bye.
Bye-bye.